ILM to the rescue. The ILM represents the structural boundary between the retina and the vitreous. By embryonic day 7, the radial cells no longer need the ILM to extend their process throughout the retina. And it was in 1919 that Morris illustrated its beneficial effects for sub-ILM macular hemorrhages. Present to you a series of cases in which ILM peeling was done for traumatic macular holes, idiopathic macular holes, epiretinal membrane, rhegmatogenous retinal detachment, optic nerve head with pit, and epiretinal membranes, also for venous occlusions and diabetic macular edema. This is a case of 62-year-old male who presented with cataract and idiopathic macular hole. The patient was subjected to cataract extraction and intraocular lens implantation. Thereafter, we proceeded with vitrectomy, stained the vitreous with triamcinolone, induced the PVD, and the ILM was stained using the brilliant blue dye. So how does it help? It takes off all the tangential traction and thus leading to closure of the macular hole. And the anatomic success improves with the ILM peeling as well as stuffing into the macular hole to a reported incidence of approximately 100% now. Thereafter, fluid exchange is performed and gas or SF6 gas is injected. Case 2, traumatic macular hole. 35-year-old male presented with traumatic macular hole vitreous hemorrhage was subjected to vitrectomy, ILM peeling, and the ILM was stuffed into the macular hole, leading to closure of macular hole. Case 3, 67-year-old male presented with ERM. Now, ERM was removed using the ILM forceps, and thereafter the retina was liberated of the epiretinal membrane and the ILM was stained using the brilliant blue dye. The ideology is to remove as much as possible of ILM without damaging the underlying retinal surface. And ILM is associated with a significantly lower rate of ERM recurrence as the scaffold is gone, and so the recurrence of ERM does not happen when you remove the ILM in such cases. And has been nicely demonstrated in a number of randomized controlled trials that with the ILM should ideally be removed. We continue to remove the ILM in this case and led to successful flattening of the retinal surface and improvement in the visual acuity. Case 4 is a 37-year-old female presenting with optic nerve head pit and serous macular detachment. Waited for spontaneous resolution, but when it did not happen, we took the patient under guarded visual prognosis. The vitreous was stained with triamcinolone acinide. Induction of PVD posed a lot of problem. Thereafter, the ILM was stained using the brilliant blue dye after having performed the fluid exchange. The advocacy is to remove the ILM to the extent that the foveal ILM is left behind. So it's a foveal sparing ILM removal for such indications. And the removed ILM is pushed into the optic nerve head. Hence, proposedly it closes and the pathway is closed and the serous macular detachment disappears. 65-year-old female who presented with diabetic macular edema non-resolving, so was subjected to ILM removal. The proposed mechanism is that it helps in the separation of posterior highlight phase, appears to facilitate the resolution of diabetic macular edema. Vitreolysis or splitting of the posterior highlight phase is a common occurrence during vitrectomy in diabetic eyes and may give false impression of highlight separation, which in reality vitreomacular adhesion persists. So removal of the ILM guarantees complete separation of the posterior highlight from the macular surface, hence leading to an earlier resolution of diabetic macular edema. 67-year-old male who presented with CRVO, non-responding to multiple anti-VEGF injection, was taken up for vitrectomy. The vitreous was stained using the triamcinolone and the ILM was stained using the brilliant blue technique. So the proposed mechanism of how ILM peeling helps in these cases is that it decreases inflammatory secondary to relief of any traction from a degeneration vitreous, as well as improves pre-retinal oxygen tension in such cases. As you can see, the ILM is being removed from the foveal area in the case of CRVO with macular edema, hence facilitating good recovery in patients who have not responded to anti-VEGF therapy. Take home, ILM peeling can cause notable morphological changes of the macula, such as thinning on the temporal side, a DOFNL, the appearance of swelling of the arcuate retinal nerve fiber layer, and a reduction in the papillofoveal distances. Nevertheless, no functional consequences is attributed to these anatomical modifications. And it's a very known fact that ILM peeling improves the anatomical success rate of closure of macular holes to nearly 100%, as reported in the various literatures. Thank you.